This is our highly successful, highly popular Department of Internal Medicine Grand Round series, the Roy Benke series, named after the founder of our Department of Internal Medicine. We had a very successful fall season, and I always like to say this is like internal medicine. I am Flix. I think Medflix is I think what we called it. So this is very much like Netflix, where we drop the first 16 or 17 episodes in the fall season, and now we are dropping the next 18 to 20 episodes for the spring going into the early summer season. We are blessed to have our interim division director, Dr. Seong Cho, from the Division of Allergy and Immunology. Seong came to us in 2015 with a dual appointment at the VA and at the Morsani College of Medicine, working with Dick Lockey, who he has the biggest shoes to fill for division director. What a great job that Dick Lockey did in his stead, and Dick remains on the faculty 50 years strong, and he continues to go with great motivation for all of his fellows and residents and faculty who work with him. But we are blessed to have Dr. Cho, who has taken on this role as interim division director in allergy and immunology to lead the division into a great 2025 and beyond. Dr. Cho was originally an ENT physician. He was an otolaryngologist in South Korea before he came to the United States, and he did his training at University of Tennessee, Northwestern, and some time at UCLA before joining the faculty at Northwestern, excelling immediately with getting grants and writing papers. His resume includes double-digit successful grants and over 70 publications and 5 book chapters. So Dr. Cho has done incredible work. A lot of that has been during his time here at USF. Today, he gives an extremely important talk on updates on chronic rhinosinusitis in guidelines of using biological agents, which I think, as he and I were talking about before here, will be a fascinating talk with so many of the internal medicine specialties now using biologics. So, Dr. Cho, I'll let you take it away, and we look forward to your talk. Thank you.
Thank you, Dr. Luzama. Thank you. And today's topic, the episode 1 of this series, the updates on chronic rhinosinusitis management, especially focusing on biologics. So CRS, chronic rhinosinusitis, used to be considered as a surgical disease. So when I received ENT training in 1990s, so when I was a resident, there were 2 different group of doctors, physicians, my mentors. All the ENT physicians, they still were doing Caldwell look surgery, opening cheekbones and removing all the sinus mucosa in those procedures. But at the same time, young faculty members, they were doing endoscopic sinus surgery. So, and then I received ENT training at that time. So then moving on, biologic agents introduced initially in asthma, in allergy field in asthma first, and then expanding indication to rhinosinusitis, of course, and other diseases. So that changed the landscape of CRS, chronic rhinosinusitis management. So then it's more and more important in medical management. So then now I would say this is medical disease, and sometimes still need surgery, but it's mainly medical management is major important aspect of management. So when I moved to USF about 11 years ago, then several years later, I participated in dupilumab clinical trial, nasal polyps. Then I participated in the writing the paper and published the Lancet paper in 2019. That is still most cited paper in my publication. So then, other biologics introduced I'm going to talk about today. So disclosures I have grant support from NIH, Regional Center for INSMED, and Upstream Bio and GSK. I'm consultant of Regional Center for NCSL Bering. So learning objectives. So interpret clinical presentation and then patient-specific factors to improve the diagnosis of chronic rhinosinusitis with the nasal polyps. And then describe scientific rationale, benefit and risk profile, and evidence-based treatment guideline recommendations for the use of biologics to treat CRS with the nasal polyps. Then lastly, utilize the multidisciplinary team and shared decision-making approaches to develop personalized treatment plans for patients with the CRS with the nasal polyps. It is important to understand the definition of chronic rhinosinusitis first. Chronic rhinosinusitis is inflammation of the nose and paranasal sinuses characterized by two or more subjective symptoms, one of which should be either nasal congestion or nasal discharge. Then you can have facial pain, pressure, or reduced smell. These subjective symptoms has to be longer than 12 weeks, then it's considered as chronic sinusitis. But when you say more than 12 weeks, that means persistent symptoms. So some people may have symptoms 1 month and symptom-free, and then you get the symptoms. That is not chronic sinusitis. That considered as a more recurrent sinusitis, but chronic has to be persistent symptoms for 12 weeks. Then you need to have objective findings by endoscopy or CT changes. On the right side, you can see images. Left side is a nasal polyp endoscopic finding, and the right side is a coronal view of CT scan. You can see in this CT scan, you can see that right side mild mucous thickening, but left side complete opacification with these gray opacities. So this confirms chronic sinusitis. It is important to understand that the acute sinusitis is an infectious disease. Its infection need to be treated with antibiotics, but not chronic sinusitis. Chronic sinusitis is inflammatory disorder. It's inflammation, so antibiotics would not help. There is also recurrent acute rhinosinusitis. It's an infection. It may be because the patient is, you have kids and you can have recurrent sinus infection, but at the same time, if you have immunodeficiency, presentation can be recurrent sinusitis, but it is still more infectious problem. But if the chronic rhinosinusitis, it's important to understand this inflammatory disorder like asthma. The prevalence of chronic sinusitis is about, according to CDC and survey data, it is 2018, it is 11.6. Compared to asthma, it's 8.4. Hay fever is 7.7. It's a pretty significantly high prevalence, but maybe overestimated because it's based on survey data. So probably experts estimate about 5 to 10%, and nasal polyp is about 2 to 3%. It is important to understand that phenotypes and endotypes of CRS. Phenotypes are clinically observable characteristics. So whether the patient has a nasal polyp or not, that's the phenotype. But even if you have polyps, but different endotypes based on underlying mechanism, pathophysiologic mechanism. For example, type 2 nasal polyp, non-type 2 nasal polyp. We're going to talk about this. And then biomarkers is important to decide what endotype it is. Why endotype is important for clinicians? Because it is chronic rhinosinusitis is not a single disease. It's a complex heterogeneous disease like asthma. So it is important to understand underlying mechanism and different endotypes, and that change your treatment plan, right? More personalized medicine. What is the type 2 inflammation? So type 2 inflammation, type 1 inflammation, you guys have some idea, but type 2, let's focus on type 2 inflammation because all the biologics we have is mainly focusing on type 2 inflammation. So type 2 inflammation in CRS starts in epithelial cells. So epithelial cells are stimulated by allergens, stimulants, or viral infection, all the infectious agents, then stimulate this epithelial cell to produce alarmins, such as TSLP, IL-33, and IL-25, and these alarmins make tissue environment more type 2 and producing IL-4, 5, 13. For example, IL-4 promote IgE production and stimulate mast cell to produce mediators, and IL-5 attract the eosinophils, IL-13 attract the basophils, M2 macrophages, eosinophils also, and cause goblet cell hyperplasia. So it produces mucus. So primary chronic rhinosinusitis can be classified based on phenotype, but also endotypes. So this is a good summary. So primary chronic sinusitis can be divided by localized and diffused. So localized means unilateral, and it can be bilateral. So based on endotypes, unilateral type 2 example would be allergic fungal rhinosinusitis, AFRS. So AFRS can be unilateral and bilateral. So here, AFRS unilateral can be type 2, and non-type 2 would be isolated sinusitis. Diffuse type 2 would be eosinophilic CRS without nasal polyp, SNP, and CRS with nasal polyp, allergic fungal rhinosinusitis. And CCAD is a central compartment atopic disease. I will talk about this. It's a new concept of nasal polyp, so I will talk about that later. And the non-type 2 example would be non-eosinophilic CRS without nasal polyps. Unique phenotype of CRS is allergic fungal sinusitis. It's not invasive fungal sinusitis, but it is allergic fungal sinusitis. There are criteria, diagnostic criteria. One is you need to show type 1 hypersensitivity, meaning that IgE is specific to fungi, and then nasal polyposis, and then characteristic radiologic finding. It used to be allergy fellows, board exam is one of the common questions in the board exam is a radiology finding. You show this a CT scan here. You can see. If you look at on the left side, you see complete opacification on the left side, but right side is completely free. So you can see complete unilateral disease. And then if you look at the maxillary sinus on the left side, you see the hyperdense area. This is a unique finding of allergic fungal sinusitis. And then pathologically, you have eosinophilic mucin and positive fungal stain. Those are diagnostic criteria. At least the 4 you need to meet to diagnose allergic fungal sinusitis. So it is also not only unique. Nasal polyp is mostly type 2, especially type 2 is all bilateral nasal polyps. But when you see unilateral nasal polyps, you need to consider allergic fungal sinusitis. Another uniqueness of allergic fungal sinusitis, most of nasal polyps is not in teenagers. So usually 18 and older. But if you see nasal polyp in teenagers, you need to consider allergic fungal sinusitis. Another one is you may consider cystic fibrosis in the past, especially neutrophilic. That is possible, but also another possibility, it can be allergic fungal sinusitis. I told you about the bilateral type 2 nasal polyps. One of the type classification is a central compartment atopic disease. It was published in New England Journal of Medicine table. You can see on the left side, published in New England Journal of Medicine in 2019, classified nasal polyps. And the last one in the square, lead square, you can see central compartment atopic disease. This is Ig-mediated allergic disease triggered by inhaled allergens and typically occur younger population. And allergic rhinitis is commonly present together. So why is it important? So this is important because most of nasal polyp, if you treat allergy, nasal polyp is still there. It's not going to be better. But if you have polyps, suspicion is a central compartment disease. If you treat allergies, their nasal polyps can be better. So on the right side CT scan, if you look at the CT scan, on the right side maxillary sinus, left side maxillary sinus, you have a mild mucosal thickening, but the disease is centralized. You see asthmoid sinus here, opacification, And sometimes polyps originate. If you look at the rhinoscope, the polyp originate from middle turbinate a lot of times. So if I see patients polyp originated middle turbinates, is sinus is clear, maxillary sinus is not that bad, then it can be CCAD, and you treat allergies. Mostly allergy treatments significantly improve their nasal polyps. So endotype, try to classify endotype to CRS. The first paper endotypes in CRS was published in JACI in 2016. This group cluster CRS with 10 subtypes. It's number 1 to 10. If you look at these biomarkers in the middle and also clinical phenotype on the right side, you can understand what it means. So here they divided IL-5 negative and IL-5 positive, and then IL-5 high. In those population, specific Staphylococcus aureus superantigen, which is a specific IgE positive, that is about 10% of population, 6 and 4, total 10%. They have high IL-5 or IgE, and ECP is a eosinophil marker. And then in this population, you see the clinical phenotype, almost 90% to 100%, they have nasal polyps instead of no nasal polyps. Then also 70% of population have asthma. So you see this population, they found that these people are more recurrent and treatment resistant. So those population is a good target for biologic agents. And then also, interestingly, aspirin allergy, allergic fungal sinusitis is this group. So these are the good candidates for biologic agents. And there is, interestingly, there is a racial and geographic difference in endotypes. This study is published also 2016, collecting samples from European countries like Germany and Belgium, then 2 cities of China, Japan, and Australia. So not in the United States, but it's Europe and Asia. If you look at the bottom graph here, it's a CRS with nasal polyp population. Green color is non-eosinophilic and blue color is eosinophilic. Eosinophilic is considered type 2. So if you look at the Belgium and Germany, it's a 70 to 80% population has a eosinophilic type 2. Australia is a similar. But Beijing and Chengdu, 2 cities of China, you can see only 20-30% of population is type 2 or eosinophilic. But Japan is an Asian country, but it's close to European countries, like 60 to 70% population is type 2. Why is it important? So let's say if you use biologics, type 2 biologics, the efficacy would not be same in China. So that is important. So, or maybe racial differences in the United States. However, so some studies show that the racial difference, there is some, but is close to 60 to 70% of population as a eosinophilic if you collect the samples from United States. So this is from United States, so from Northwestern. And then when they look at these endotypes based on type 2, type 1, type 2, type 3, if you look at the CRS with the nasal polyp on the right side, about 87% type 2. So close to 90% is type 2 disease, which means that this population is good for biologic agents. CRS without nasal polyp is about 55% type 2. The dogma in the past was of CRS without nasal polyp is likely neutrophilic type 1, but now more and more data show that actually it is more than 50% is type 2. So this population would be a good target for also biologic agents if you use the type 2 biologics. So let's move on to medical management of chronic sinusitis. This is a good summary table to look at what management we can use, especially medical management. I will talk about a little bit of surgery too. So when you diagnose chronic rhinosinusitis, remember it's at least 12 weeks, 3 months persistent symptoms. Then you confirm with the rhinoscopy or CT finding. Then the first line treatment is intranasal steroid and nasal irrigation. If you fail, in the past, mostly surgery, but now it's different. If you look at the CRS with nasal polyps on the left side, EDS FLU. So I'll talk about this. This is exhalation delivery system fluticasone is one treatment, and CCAD you can use allergy immunotherapy as I mentioned. Then you have a biologic agent and oral steroid short term, then sinus surgery. So these are the treatments. AER, the aspirin exacerbated respiratory disease. There are two differences in this in the management wise. One is aspirin desensitization. You can do aspirin desensitization. Another unique treatment is leukotriene inhibitors. So mostly nasal polyp leukotriene. There is no evidence that leukotriene inhibitor helps, such as montelukast, but ARD is different because the mechanism is increased leukotriene mediators. So you block leukotriene inhibitor that helps ARD patients. And next one is a CRS without nasal polyps. You do surgery. In the past, that is a main measure of management. You can use macrolide antibiotics. This is not infection, treating infection, but it's inflammation. You use long-term macrolide. You can use 3 months of macrolide to calm down inflammation, mainly targeting neutrophilic inflammation. And then you can do also EDS-FLU. Recently, FDA approved this EDS-FLU and exhalation delivery system fluticasone for CRS without nasal indication. On the right side is allergic fungal sinusitis. In the past, as mainly surgery was a mainstay of treatment, and antifungal agents. There is no, strong evidence of antifungal agent use, and also allergy immunotherapy can help targeting mold. But that's it. But now, recently, phase 3 clinical trial of dupilumab just finished. We participated, our CLU participated, and just finished. We are waiting for the result. And if it is successful, dupilumab can be important treatment for allergic fungal sinusitis. Now, as I said, surgery has been very important management option for CRS with nasal polyps. But what are the challenges in surgery? This is important to know as an internal medicine subspecialty, because it is we need to understand some of the surgical aspect too. So CRS with nasal polyp is an inflammatory disorder, mainly type 2 eosinophil process. So the idea is to remove inflamed tissue by surgery, at the same time improve ventilation of the sinuses. So there are 4 sinuses, and opening up those sinus openings so that improve ventilation. That is the idea of surgery. But the problem is the study showed that the endoscopic sinus after surgery, 2 to 5 years, study showed that 40% of these people had polyp recurrence. That is a problem. Another problem with endoscopic sinus surgery is the surgery result depends on operator. So you have a general ENT surgeon, and also you have specially trained in rhinology, meaning mainly focus on training is rhinology sinus surgery. So if you refer patient to academic institution like USF, eventually rhinologist will see the patient and do the surgery. But if you refer outside academic area, this patient may go to general ENT physician. Their skill may not be as good as a rhinologic surgeon. So surgery result depend on operator. You need to remember that. And also important limitation of sinus surgery is if you look at the CT finding on the left side, OC means olfactory cleft. So nasal cavity, ceiling of nasal cavity and brain is divided by lamina cribrosa, which is very thin bony structure. And then olfactory mucosa is mainly distributed in this ceiling of nasal cavity. So if you approach with the surgery, it's difficult to remove all the inflamed mucosa here because the risk of brain injury. So they are scared to use all the inflamed tissues. So that's a limitation. Another limitation is also, if you look at the right side, this ethmoid or frontal opening area is very close to orbit. So this is also difficult to remove all inflamed tissue. And there is a visible also limitation to approach the frontal sinus openings. That's why general ENT surgeon sometimes afraid to remove all this area inflammation, the surgery result is not as satisfactory. So that is very important. So compared to, if you look at the compare endoscopy dupilumab, especially smell restoration, is dupilumab is superior than endoscopic sinus surgery because of this reason. So you can use a systemic drug to improve inflammation, and then they have much better result than endocrine sinus surgery. When you look at the biologic agent data, phase 3 clinical data, the primary outcome, there are two primary outcomes, all biologic clinical trial. One is objective primary outcome is endoscopic nasal polyp score. Second primary outcome is nasal congestion score, symptom score. So it is important to understand to know this nasal polyp scoring system. So if you look at the right side picture, NPS, nasal polyp score 0, NPS 1 is a 1. This NPS, nasal polyps are limited inside the middle meatus. So this is a middle turbinate. This is inferior turbinate. This is a maxillary sinus, right? So then NPS 2 is beyond the middle turbinate border. So there is a score 2. If it's all the way down to inferior border of inferior turbinate, that is a 3. All the way down to the floor, there is a 4. So both sides, the total score is 8, right? So what is the meaning of this scoring system? If you see 1 point and more improvement, there's a good response, considered good response. But it's the 2 and more is excellent response, which is close to oral steroid. If you use oral steroid like a prednisone, people study this and then realize that this is about NP score, nasal polyp score 2 and higher improvement. Okay, so then when you look at the clinical trial, I'm going to show you, keep that in mind. This is a EDS fluticasone, so exhalation delivery system fluticasone concept. So conventional nasal spray uses just a spray, but this one is using the mouth blowing power, the medication delivered inside the nose. So if you look at this image, the yellow area is medication distribution. So you see that the medication distribution is limited in anterior inferior portion. But if you look at this exhalation delivery system, medication distribution is widely spread. So that's the concept of this EDS fluticasone. So in this clinical trial published in 2018, this is a placebo arm, and then 2 different doses. So this is 1 spray twice a day. This is 2 spray twice a day. If you look at the difference of nasal polyp score, this is nasal polyp score. This is about 0.6 improvement. If you use 2 spray twice a day, that is about 0.8. The insurance usually covers 1 spray twice a day amount. So if you look at that, it's a 0.6 improvement. 1 point improvement, as I said, it is a good response. This is a 0.6, right? So this is not good response or excellent response, but significant response. So that's the limitation of this medication. So now let's move on to biologics. So initially, as I said, dupilumab is approved. What is dupilumab? It is a IL-4 receptor blocker, blocking IL-4 and 13 cytokine pathway. So that is one. And then mepolizumab is blocking IL-5, FDA approved. The benralizumab is approved for asthma, eosinophilic asthma. They did a clinical trial, phase 3 clinical trial, but not satisfactory. So they are doing second phase 3 clinical trial now is ongoing. The difference is they are focusing on high eosinophil people and see if that's better. So then omalizumab is FDA approved indication for CRS with the nasal polyp blocking IgE. So biologic agents is not for all patients who have nasal polyps. It's a severe cases, refractory cases. So these are the criteria required for biologic treatments. So out of 5, these criteria, you need to have 3 criteria. So the first one is you need to have evidence of type 2 inflammation. By what? By eosinophilic inflammation, right? So either tissue eosinophil, but previous surgery, you have a biopsy result, right? So some pathology may mention it, but most of actually biopsy pathology result, you may not see it, is high eosinophils in the tissue, or blood eosinophil is 250, or high IG is high. So those are type evidence of biologic, sample, either sample or blood sample, evidence of type 2 inflammation. Then you need to have a disease that's significant enough to use a systemic steroid, bad enough to use a systemic steroid, or you want to use it, but contraindication of systemic steroid. More than 2 courses per year, usually that is considered as a significant. Then significant impaired quality of life and the loss of smell, and the diagnosis of comorbid asthma. So loss of smell, meaning that it is probably large polyps, and also comorbid asthma generally indicates that the patient has also bad nasal polyps. But this loss, reduced smell, and then comorbid asthma is interestingly is also indicating that the patient has a type 2 disease. It's a clinical marker of type 2 disease. So then when you start the biologic agent, you need to follow up these patients. In terms of evaluation, you need to keep in mind these 5 criteria. So reduce nasal polyp size with the rhinoscope. You look at the patient with rhinoscope, and also reduce need of systemic steroid, and improve quality of life, and improve sense of smell, and also impact of comorbidity. So for example, not only nasal polyp is better, symptoms better, but also asthma is better controlled. Those things are 5 criteria. If you have 4 to 5 criteria met, it's good and excellent response. 1 to 3 is a poor to moderate, and no response, 0 criteria. So I usually do follow up at least 4 to 6 months after starting biologic agents and evaluate. So you have an excellent response, continue. No response, may consider to stop, but it's maybe poor to moderate. You may consider 6 more months treatments, and then you decide. So there are challenges in biologic agents also. So compared to surgery, generally it's more expensive. And also, when you start, you don't know when to stop. So no clear evidence of disease resolution. So real-world studies show that you can extend the interval of the biologic injection. So that's what I usually do. Let's say if I start dupilumab is every 2 weeks, I extend, if the patient is doing well, I extend to every 4 weeks, sometimes every 6 weeks or 8 weeks interval, so that the patient doesn't need medication all the time. So that is and then eventually maybe 3 months and 6 months is a possibility if patient is doing well. And it is important to understand about endotype selection. It's all type 2 disease. But what kind of type 2? Even among the type 2 is maybe different. So that's why the biomarker is important. So, for example, I'm going to show you data with the dupilumab, omalizumab, and mepolizumab. If you see some patient is very well, mostly well respond to dupilumab, but some patients well respond to mepolizumab, but not some patients. So then what's the difference? That is very important to understand that. Benefit of a surgery is a smell restoration, and then you can also have asthma getting better, or other type 2 comorbid condition better. And there are some side effects, but those are usually minor. Conjunctivitis is common, and also sometimes rarely cause joint pain or rash. So one by one, let's quickly go over. The medication dupilumab is anti-IL-4 receptor monoclonal antibody. They did 2 clinical trials, Sinus 24 and 52. So left side is nasal polyp score, NPS. On the right side is a subjective symptom score, nasal congestion score. So there are 2 studies, Sinus 24 and 52. Placebo is the purple line, and the blue line is a treatment arm. You see, you can see that the 8 weeks first, when they check the nasal polyp score, is already 1.5 improvement, and 24 weeks is a 2-point improvement. So it's an excellent response. You can see this is not good, but it's an excellent response. And Sinus 52, the difference of this trial is one arm, they continue every 2 weeks, right? Another arm is a little bit stronger blue color, and lighter blue color is every 2 weeks is initially, 24 weeks they extend to every 4 weeks. You see, in this change to every 4 weeks, there is not much difference in terms of nasal polyp score, and symptom scores are similar. So you have a significant improvement with the treatment arm. And also there is 2 different treatment arms, dupilumab, but even though you change it every 4 weeks, there is no significant difference, also symptom score. So you can see that probably 6 months later, you may change to every 4 weeks. This is a systemic steroid or nasal polyp surgery rescue treatment. You can see placebo is of 42% of this requirement, but the 12.5% if you use dupilumab. So significant reduction of systemic steroid use or surgery. If you look at the safety adverse event, the treatment emergent adverse event is not big difference compared to the placebo here in dupilumab, this column, but there is no big difference and no serious adverse effect. So let's go to omalizumab. This is anti-IgE. Also, the omalizumab has 2 phase 3 clinical trials, POLYP 1 and POLYP 2. So left side is nasal polyp score, right side is nasal congestion score. If you look at 2 purple lines, it is placebo. If you look at the 2 treatment arms, you can see about 1 point improvement. The dupilumab was a 2.2 improvement, and omalizumab is about 0.1 improvement, good response. Although not excellent response, good response. But pretty quickly, 4 weeks later, even 4 weeks later, there is a significant response and then plateau, right? And then significant nasal congestion improvement. So when they look at the quality of life score, secondary outcome, like it's not 22, you see significant improvement. And when they divided this individual quality of life score, nasal symptoms, otolaryngology symptoms, sleep, and all got better. This is important scientifically, and then look at the endotype aspect is very important. If you look at subdivided in this omalizumab study, nasal polyp score more than 2-point improvement. There is some population is more than 2% improvement, although average is 1 point improvement, right? If you like, as I show you here, but there is some patient has a 2 point and higher improvement. That is about 30%. 1 point improvement is about a little higher than 50%, right? But only 30% is higher than 2-point improvement. So, and also if you look at the placebo has a 1 point improvement is about 30%. Placebo, they can see the placebo effect, maybe because they use nasal steroid continually, regularly with the monitoring. That's maybe that effect. Adverse event is a placebo, and the omalizumab, there is no big difference and also no serious adverse event. Now, mepolizumab, anti-IL-5. So this study is the same, called the Synapse, and this is differences compared to previous 2 studies. This is the 52 1-year study instead of 6-month study. This is nasal polyp score. This is nasal obstruction score. It's the same. All primary outcome is similar. So placebo, compared to placebo, at the end of the study, you can see about 1 point improvement, right? So, however, 24 weeks, if you look at the 24 weeks, about 6 months, their score improvement is about 0.6 improvements. It's not impressive, right? But at the end of 52, 1 year later, you see 1 point improvement. So compared to omalizumab, is very quickly respond week 4. Actually, this one, week 4, already about, close to 1. And then if you look at dupilumab, you can see that the 8 weeks, week 8 is a 1.5. So that is a difference. So it seems that the Nucala, the mepolizumab, is slowly acting on and eventually 0.1 improvement. And secondary, so endpoint is all better. Like, for example, it's not 22 quality of life score and the use of systemic steroid or nasal in the nasal polyp all improved. So this one, if you look at divide the subgroup, if you look at these nasal polyp score, 2 point, 3 point improvement, 4 point, 5 point, even 5 point improvement, 2 point and higher improvement. There is a, yes, if you use mepolizumab, there are some population, about 30% or above, population higher than 2-point improvements. It is important to find out this population who is very well respond to mepolizumab. However, if you look at no change, even about 27% of population, no change, 30%, almost 30% is no change, like a placebo, right? And then 22% is even worse in terms of nasal polyp score. So that's very important to understand. And if you look at the right side, let's divide some other clinical characteristics of our eosinophils. If you have patient have asthma, if you look at patient, if patient has asthma, yes, there is a good response in nasal polyp score. But if patient has no asthma, there is no significant benefit. If you look at the eosinophil count, if your patient's eosinophil is less than 150, you can see the overlap. So there's no effect in terms of nasal polyp score. But if you have high eosinophils, yes, that is effective. So in this study, also safety study, no serious adverse events. So this is a good summary of the table to see overall, and how you look at this table is if you look at the color of this, what does it mean, this color? So this is a green color is among most beneficial, lighter green is among intermediate beneficial, and then purple color is among least beneficial, right? If you look at that, and then you have dupilumab, omalizumab, mepolizumab, 3 FDA-approved products, and this side is a patient subjective outcome, right side is objective outcome. You see, dupilumab is all green, except one adverse event. It's the same. It's supposed to be not beneficial, right? So omalizumab, 2 green, and mepolizumab, 1 green. You can see just look at the color. You can see there is some performance looks to be dupilumab is performing better than 2 other biologic agents. But keep in mind that there is some subgroup is as good as dupilumab if you use omalizumab or mepolizumab. That is important to find out those subgroups. So this is a kind of a little bit of summary. Chronic rhinosinusitis with the nasal polyp seems to be, dupilumab seems to be overall winner, and omalizumab and mepolizumab, however, may be as effective as dupilumab in some patients. So finding out those patients is important. So allergy immunology, that is our subspecialty, allergy immunology subspecialty person's job to find out which population is good. For example, let's say really high eosinophils, so about higher than 10,000 or 1,000 eosinophils, maybe this case is mepolizumab would be good, because if you use dupilumab, there's a transient increase of blood eosinophils. So mepolizumab from the beginning maybe use this one, may be better. And dupilumab sometimes cause some joint pains. So maybe rheumatology, colleagues may be interested because it is, the understanding is possibly Th17 pathway is increased because it's blocking 2 type 2 inflammation marker, and interleukins are blocking it. That's why maybe Th17 cytokines increase. That's maybe the reason. Then you may switch to omalizumab or mepolizumab. So now the tezepelumab anti-TSLP is approved for asthma. That is they are ongoing now, phase 3 clinical trials, and they will conclude, and then soon the result will come out. There is a ending, and then there is a phase 3 also clinical trial coming, IL-33, another alarmin blocker. Lunsekimib is very important. It's an interesting molecule. It blocked the TSLP IL-13 together. So they show that there is a stronger anti-TSLP effect than tezepelumab. So maybe supposedly better, possibly in the clinical trial. So there's coming for CRS with the nasal polyp. We are participating lunsekimib at the VA, actually. We are starting this month, lunsekimib clinical trial of CRS nasal polyps. And this is anti-IL-33. Will start in USF side soon. And then also, as I said, CRS chronic rhinosinusitis without nasal polyp, more than 50% is probably type 2. So We did a single center clinical trial, just finished recently, dupilumab, using this CRS with a nasal polyp with high eosinophils. We recently finished. We need to look at the result. But non-eosinophilic, what about non-eosinophilic CRS? So we are doing clinical trial in brensocatib, which is a DPP inhibitor, peptidase 1 inhibitor. So I don't know, you guys, probably pulmonology colleague may know, bronchiectasis, non-cystic fibrosis bronchiectasis, phase 3 clinical trial with this molecule is completed, and they showed that the significant improvement of exacerbation, bronchiectasis improvement, flare-ups. So this result will come out and then soon possibly FDA approved. So this one, they are targeting also CRS without nasal polyps. So we are doing clinical trial now. If you have patients, please send. And then other probably biologic agents would be possibly effective in CRS without nasal polyp subtype. So some barriers, not only some understanding the science, but also you need to understand the social science. So physician-related issues can be a barrier. So either when a patient goes to primary care or allergy immunologist or ENT specialist, there can be different approaches. And patient-related issues can be age-related, also comorbid conditions. And also it can be system issues. Some insurance companies cover one biologic but not other. So those things can be issue. So it is important the primary care physician to refer patient to proper subspecialty, especially there's some patient wants to really have surgery done, especially young population, then you can send it ENT, but they don't want surgery, then you need to consider first allergy immunology subspecialist. This is a good website. American College of Asthma, Allergy, Immunology have some decision-making tool while working together with American Rhinology Society. You can go to this website and then discuss with the patient. So there is options. You can discuss about management options of CRS with the nasal polyps. So I'm going to go over quickly 3 cases. The first case is Brian. So he's young, 42, and newly diagnosed with CRS with nasal polyp. Nasal polyp confirmed the rhinoscopy, bilateral polyp, but polyp score was 4 out of 8. And the CT confirmed also chronic sinusitis. What would be the next step of cost-effective management of Brian? So you can think about it. What would it be? So this is young and newly diagnosed. And here the question is cost effective. So as I said, biologic agents are generally more expensive than surgery. So you can consider surgery. Another important aspect is the nasal polyp score. So all clinical trial biologics, nasal polyp score has to be higher than 5 out of 8. So this is 4, meaning that there's a smaller polyps, then surgery would be better indication. So here, balloon sinuplasty, there is no evidence to use balloon sinuplasty to help nasal polyps. So functional endoscopic sinus surgery would be option. Here the answer, right answer. Case 2, this is a little different. Tom is 72, and CRS with nasal polyps and surgery 3 times, but the polyps come back and confirmed nasal polyp, rhinoscopy confirmed that the nasal polyp score is 5 out of 8, pretty large nasal polyps, CT confirmed. And patient also not only polyp, but also asthma, diabetes, coronary artery disease, state positive CABG. So the question is, what is the best choice for Tom? So balloon sinuplasty, dupilumab, benralizumab, functional endoscopic sinus surgery. This case is different because it's old, comorbid condition. There is a surgery risk, already came back. The polyp came back, tried 3 times. The best is biologic agent. Among the biologics, dupilumab would be the choice. Benralizumab is not a good choice because it's not FDA approved yet. They are doing clinical trial. So this is number 3, last case, Tiffany. She's young, 34, and confirmed nasal polyps, and score is pretty high, 6 out of 8. And then she has also asthma with the fluticasone, salmeterol. And then she has also a history of NSAID or aspirin allergy. So she has a wheezing, coughing with the NSAIDs. So the question is, what is the proper order of management for Tiffany? So now before biologic was introduced, so surgery was very important, right? If you fail intranasal steroid and surgery, another important aspect is aspirin desensitization. So then what are the biologic role? So there's a question about. So, and then what is the order? So usually, let's say if you use a biologic agent, that can be the first choice, and you can do this without surgery. That's possible. But if you do consider surgery, then you do surgery first and aspirin desensitization, because aspirin desensitization before the surgery, if you don't do for surgery and a lot of huge nasal polyp, you do desensitization, patient can have reaction during the desensitization, asthma flare up, and it can be risky. So usually what we do is remove the bulk of nasal polyps, and then you do nasal aspirin desensitization. And then patient has polyps come back, then you may consider biologic at that time. So that is the right order. Number 3 is the right answer. Okay, that's my talk. 1 minute pass. So I
You did
will
fantastic.
take any questions.
That was very well timed. Thank you, Sung, for an excellent review. I want to see what questions we want to go with. Jen, do you want to drive some of the questions? We have any hands up?
Nothing in chat right now.
Okay, perfect. Don't be shy. I know it's the first session. It's a little chilly out there. But Dr. Cho has warmed you up with this discussion. I really enjoy the cases at the end, really brings things together. I want to let you know that Dr. Mosley was tied up with a lot of executive meetings at TGH today, but he wanted to pass along his gratitude for everything you are doing as interim division director, and was very happy to see you as the opener for our spring to summer series of Grand Rounds lectures. So I want to make sure to pass along his excitement as we start this new season.
Okay, thank you. Yes, I think it is maybe I went through too fast, maybe, so to keep the time. But yeah, so any questions? So this is
I like fast paces. I like 41 to 40 football games. Much more than I like 10 to 7 football games. So, but no, I think there's an excellent review.
Yeah.
You've
Okay,
got even the people using biologicals
yes.
with no questions.
Right. So I think it is a biologic that definitely changed the landscape and expanding now more and more new biologics coming out. And then they are now, initially there was an asthma, right? Asthma application. Then now it's expanding to CRS nasal polyps, and then eosinophilic esophagitis, and then urticaria, and now there is some other rare disease that people are using these biologics, and then now when companies develop new biologic agents for type 2 targeting type 2, they are now doing both asthma trial at the same time, and then polyp trial. So lunsekimig, as I said, they are doing phase 2 for lunsekimig, which is blocking TSLP and then IL-13, but they are doing both asthma trial at the same time CRS within a polyp trial. So companies are really pushing out to use this biologic agents more available. So it's expanding. So since I started dupilumab trial, then nonstop, continually there is some clinical trial coming in, and we are doing continuous clinical trial with the CRS with the nasal polyps. So this is, really exciting area in terms of understanding about the mechanism of the disease and teasing out the mechanism and also treatment aspect too.
Absolutely.
There's one question in chat here.
Oh, go ahead. Absolutely.
Can you please share some insight on the role of allergen immunotherapy in patients with nasal polyps versus biologics?
Okay, that's very good question. I think it's roughly about patient with chronic rhinosinusitis. About I would say 50 to 70% has atopy allergies if you do skin test or blood test. But there has been no clear evidence that the allergy immunotherapy would help, especially nasal polyps. But as I said, the New England Journal of Medicine table I showed you, central compartment atopic disease, which is if you look at if you go and then look at with the rhinoscope, you can tell, oh, this is different from regular nasal polyp. Regular nasal polyp is originated usually in middle meatus and uncinate process area, but this polyp is originated in the middle turbinates. You can tell. And then that is usually not big, not that big. It's not obstructive usually, but there is a polyps. And those polyps considered as a CCAD. In this population, I started allergy shots, allergy immunotherapy, and they get better. Their symptoms are better. Their polyps are even goes down. So I see that those populations, selected population of nasal polyps, allergy immunotherapy definitely help. But let's say type 2 big nasal polyps maybe is assistance, right? You can do if patient has a significant nasal, allergic rhinitis, seasonal allergies, you do allergy immunotherapy that helps. But there is no strong evidence that the polyp size decrease or polyp symptoms better, like for example, smell loss and those things. But certain nasal polyps, yes, allergy immunotherapy is an important aspect of treatment.
Very good. All right. Well, thank you, Dr. Cho. I want to say we're very excited about this next 6 months, really, of the whole education picture, with Grand Rounds being one of the key players. We will have Grand Rounds every Thursday all the way to the end of May. We will be finishing up toward the end of May with one of our second in the series, Emerge, run by Dr. Gupta. And we're very excited about having that in May as well. Would be remiss if I didn't mention Dr. Gupta is running her second annual hospital medicine conference. That'll be on March 6th, Thursday, March 6th at Tampa General. And she has been sharing this with widely, but I wanted to also advertise it here in Grand Rounds. We are having 3 outside speakers coming this series, that are coming here. So Dr. Daniel will be our first from UT Southwestern at the end of the month, and he's going to talk about leadership, organizational change and leadership, which I think is going to be a fantastic talk. We're going to have Dr. Aiken in today's realm of allergy immunology talking on mastocytosis, and we are very lucky to have Dr. Tucker, national expert from UAB, who'll be talking in hospice and palliative care, who's being brought to Tampa by TGH, and will give Grand Rounds during the month of February, at the end of February. So just a dynamic lineup of speakers going every Thursday till the end of May. Really looking forward to bringing you the best CME and hopefully having some fun and being a bit entertaining as we can be. So want to thank, as always, Jen Newcomb. She's the unsung hero that makes things run here for our Grand Round. So thank you, Jen, for all your great work. And also to thank Dr. Mosley for his continued support as our chair of Internal Medicine. I'll close it here. We are even at 12:58. So one of our goals was to stay right to this hour. And so thank you, Dr. Cho, for excellent talk and absolutely perfect timing. And I hope you all have a great Thursday, and go Bucks. Take care.
Okay, thank you.